So good afternoon and welcome to all of you to this webinar by Professor Anindya Chakrabarti as well as joined by Mr. Hardik Dedhia. So my name is Tarun Jain. I am a professor of economics at the Indian Institute of Management in Ahmedabad. I'm also the chairperson of the Institute's Center for Management of Health Services. Today what we have is a very interesting hour-long discussion on quite an important topic, which is, let me just characterize that as digital health and the potential of the internet to radically change the healthcare landscape in India. Now, the two speakers for today first one is Professor Anindya Chakrabarti, who has been one of the, I think, leading colleague of mine who has been analyzing the effect of the internet and many other kinds of technologies in the healthcare space, especially with a focus on the last 2 or 3 years, right? So when the COVID pandemic started. So Anindya is going to be, is an economist. He's been at the Institute for a number of years, and he's been working both on macroeconomics as well as the health economic space. And so he has recently published, along with a PhD student as well as other colleagues, a paper on how the pandemic changed technology engagement in India. So welcome, Anindya, and look forward to your talk. The second speaker that we have today is Hardik Dedhia. And so Hardik is an engineer who was one of the founding members of API Holdings. Now, this is a very important company in the digital health space. Many of you might not have heard of the term API Holding, but it's quite likely that many of you would have his customers, right? So if you have heard of ThyroCare or if you have heard of Pharmacy, these are all companies that sit within the API Holdings group. And so, this is a group of companies that is transforming the mHealth space quite radically in India. And you will see that this is, you will see as well as experience the transformative impact of this kind of work, right? So welcome, Hardik, and we look forward to your discussions, to your views on this matter today. So without much more ado, let me just introduce the format. Professor Anindya will be taking the first 20 minutes or so of the seminar and discussing his research. Then we look forward to Hardik's views on this topic for the next 20 minutes. And then at the end, we have a number of attendees in this webinar, and we look forward to your questions. And obviously, right now, we put you in the sort of audience mode. I do see a hand up, but we will include you and have you give a chance to ask your questions live to the audience members and hopefully have a productive discussion time. So without much more ado, Anindya, the floor is yours for about 20 minutes.
Thanks, Tarun. I am audible, right?
Yes.
Yeah, okay. All right, so I have shared my screen. So I guess the screen is also visible to all of you. So first of all, I really appreciate Tarun giving me this chance to present our work. So this is something that we have been doing for some time, and I would also like to thank Hardik for joining us and kindly reading the paper, and look forward to listening to your thoughts. So this idea is something that we started working on a couple of years back. I'm here my colleagues. So Sawan is my PhD student at IIMA. Chirantan was both mine and Tarun's earlier colleague. He is currently at University of Sussex. And Aparna is actually one of the, one might say that she was actually the catalyst for which made us think about this kind of a problem. So she is a physician, trained doctor, and she is a very accomplished one at that. And she also runs an NGO named Arman. And it's only through them we got to know a particular type of healthcare intervention that they do through internet, through phone calls, sorry. And that is what kind of, sparked our interest, and we started, collaborating on the data that they have been generating. So we called this paper "Pandemics and Technology Engagement." based on evidence from a pretty large scale, ML intervention. And currently this paper, around 7 or 8 months back, I think this paper was published in Review of Development Economics. So if you are, what I will do today is to give more like a broad overview of the topics that we will have covered. If you are more interested in the details, then I request you to refer to the published paper. So the context of this work was this Arman. So this is an NGO that Aparna had set up. So what they do is that they give, they have this particular service called Mitra, which is a short form of mobile, and then Mitra is friends. They give make phone calls to underprivileged women who are pregnant. And I will give you more details about what kind of phone calls there, but these are roughly, for recorded phone calls with information about what kind of medicines these women have to take, or what kind of precautions they have to take, etc., etc. Typically, these are kind of pre-recorded messages. So what we can see is, a roughly data set of comprising almost 2 million phone calls. All of these phone calls were made to women, mostly around Mumbai, and typically these are they reside in the slums of Mumbai. And the idea is to see that the problem is as follows. So the technical problem that we wanted to think about is follow. So just keeping that in the background, that there's the context. So think of it like this, that we know that, these days cost of information provision is actually very low. It has, due to technological revolution, it has gone down drastically, and it's almost now dirt cheap to provide information. So what started happening is that there are two things. So the policymakers started seeing that that there can be many problems which can be negated by providing more information. So if the information provision is almost costless, so they can push information by utilizing communication medium at a mass scale. And this is something we have seen time and over again. So if you think about during the COVID time, so all of us would probably remember that at the beginning of each and every phone call, there would be a pre-recorded message where people would be asked to take certain precautions, or in case certain symptoms appear, then they have to talk to physicians and so on. So those kind of informations were there. The critical point is that it's not particularly clear whether the demand for information is there or not. So it's easy to provide, easy as in technologically easy to provide or create the supply of information. And we have seen that, that happens in many cases. But do people actually listen to that? And if they don't, or if they do, in case they do, then all right, the problem is solved presumably. But in case they don't, it's very important to find out exactly where does this supply and demand mismatch appear? What are the reasons for this friction? Now, before we get into the details of what do we mean by a friction, etc., etc. So let's think of the problem this way. So just kind of like an anecdote. So after this pre-recorded message started playing during the COVID time, I just informally just went out and asked a few of my friends and neighbors and so on over a phone call, that do you actually listen to the message, and can you tell me what was there in the message? Generally speaking, because my own impression was that I myself almost always ignored the message. Yeah, I listened to it, but I almost always ignored the message. I do not recall the details of it. So it was more like something that is being played in the background, and what I'm waiting for is that somehow it will end and then I will get to what I'm supposed to do. So there is kind of an attention deficit, one might say. So if that happens at a mass scale, then one can actually ask that, theoretically speaking, then what is the point of providing information that way? Or is there a better way to provide that information? So the point that I'm trying to get at is that these frictions are real. This is not a made up point that people often, even if the information is there, people are not going to necessarily act on it. So this is where we sort of started thinking about, utilizing this Harman database to think about if one can exploit some kind of an exogenous variation in terms of whether people are actually listening to the phone calls or not. In that case, we will be possibly able to figure out what are the exogenous factors that is causing people to listen more or listen less to a given set of messages. Why is that important? Because we know that there is currently a lot of discussion going on around, this is part of United Nations goal, that along with the traditional ideas of, income and wealth, rich and poor divide, urban and rural divide, and so on. So something that we are very familiar with in economics. Currently, one of the biggest difference that is appearing is in terms of information. There are information-rich people, there are information-poor people, and therefore, one way to think about, kind of creating a balanced platform where one can, one can have access to all sorts of information is to work on the supply side of the information. What we found is that the demand side is actually not very well studied. I mean, currently people have started studying it, but that is very recent. That's a very recent phenomenon. There is one paper that came up in Journal of Development Economics 1 year back. It's by Sadish and Achyut. I think Achyut Akbar was also an author of this paper. So what they wanted to do is in an Indian plant, I think some kind of a manufacturing plant probably. So they were trying to see whether misinformation about COVID was prevalent or not. And what they were trying to see is that if you have different modes of engagement, it can be either through direct phone calls or pre-recorded messages, etc. So which kind of intervention is more useful in order to reduce, let's say, misinformation? So the problem of this kind of things is that active phone calls, what they saw is that active phone calls are more useful. But the problem of active phone calls is that it's prohibitively expensive. One cannot really make active phone calls to 1 billion people and somehow make them aware of something. So we have to generally rely on kind of pre-recorded messages. That is where the problem begins, that if we really rely on pre-recorded messages, we do not know what are the reasons as to why people may not necessarily listen to them. And then there is a worldwide there is a whole bunch of examples now where different countries, developed and underdeveloped or developing alike, where there is a whole host of kind of intervention through text messages or phone calls or recorded phone calls, etc., etc. So I will skip all of that because I don't have a lot of time. I will just give you the broad data universe and the idea of some causal estimates that we causal econometrics that we did. So what we have as a data set is, let me actually just directly show you the specifics of the data set. So this Mitra phone call, what they do is that for each of the women who have been enrolled to take this service, there's a free service, by the way. Throughout their pregnancy, if they were, so let's say it's a 9-month period for each woman. So throughout over these 9 months, these women will get 141 individualized kind of voice messages, which range from 60 to 120 seconds. Not all messages are, of the same length. So some of them are shorter, some of them are longer, etc., etc. What we can do is that from their database, we can observe what was when did the given woman pick up the phone and when did she put it back. So let's say that if we know that the message goes for, let's say, 90 seconds, we can see whether she put the phone back within 10 seconds or not. So she just picked up the phone and maybe she was busy doing something else, just puts the phone back. So we can see it at the level of a fraction of a second, that when does she put it back. So based on that, so one variable that we have is exactly the number of seconds that she is listening to. The other one that we have is kind of a gradation. So there are 3 grades. So one is a green zone, the other one is a orange zone, and the last one is a red zone. Red zone is something where one is just picking up the phone and then putting it back. So there is no engagement whatsoever. Green zone is when someone is listening to, let's say, more than 2/3 of the message, and the orange zone is in between. So we have some kind of gradation like this as another observed kind of variable. And for each of these women, we have some demographic variables, and that is actually a very important thing. So for some of the variables that we have is a rough estimate of their income. So it's actually a shame that we do not have a bigger description of their demographic kind of context. But when they are being enrolled, they are asked about what would be roughly their per month income. The second thing that we have is whether the phone belongs to them or to their husband or not. So the phone ownership, the thing is there, and that is very important for information provision or information acquisition. Let's say, even if it's provided, whether it's acquired or not. And the other thing that we know about is how these women were enrolled. Did they enroll by themselves? They went out and got themselves enrolled, or through community workers, they were enrolled. So in some sense, whether there was an outreach program to them or not, we know it at an individual women level. So based on that, what we have is a unique database of almost 2 million, phone calls ranging over 2 years. And technically speaking, what we do is something like difference in difference estimate. It's, basically the idea is as follows, that I will get to a figure here. So this picture kind of shows our main kind of analytical specification. So this is something that we call the treatment group, that all the women that were there from January 2020 to July 2020. So April 2020, we assume that this is the sort of month when COVID lockdowns began. And this is sort of the treatment group in the sense that we are utilizing COVID as a treatment. What does that mean? The idea is that whether people are willing to, let's say, pick up and engage with technology or not. So here engagement with technology is whether they're listening to the messages fully or not. That depends on their time availability. And time availability has an opportunity cost. So opportunity cost is an economic idea that I guess pretty much everyone knows in this in this talk, so therefore I'll not get into it. The point is that if she is busy doing something else, so maybe working as a maid in someone else's house and so on, and a phone call comes, a message comes, she does not have the time to actually pick it up. Vis-a-vis, when COVID strikes, people are stuck in their home, the phone is there, and that is actually especially true if the phone belongs to the husband. So given that due to the lockdown, most of the people, not only were stuck in the home, they lost their jobs and so on, they will be stuck in their home. So the phone will also be accessible to the women. Otherwise, what will happen is that maybe the husband will just, take the phone out when he is going out for work. So the availability issue can be resolved in that sense. So when COVID begins, there is a high chance that phone will be more available, and there will be a lot more time availability with respect to the women in order to pick up that phone call, and therefore she can engage more with technology. There is another argument in favor of it, which is that I think just before this began, we were discussing, and as I think Tarun and Hardik both pointed out, that it was only during COVID that people started thinking a lot about general kind of illnesses and what kind of systems are there to tackle, etc., etc. Chances are that pre-COVID, people were getting messages, they never bothered. But once COVID strikes, then all of a sudden they become much more attentive to all sorts of information that is being provided regarding their health issues. So there are multiple reasons effectively to expect that the technology engagement behavior in terms of at least listening to these phone calls will increase during the lockdown time. So that is something that we can, technically speaking, we can call it a treatment group, in the sense that this cohort of women were treated with sort of COVID. in a statistical sense. I don't mean COVID literally. They had COVID. So it's just that this group went through the time of COVID. And the control group is, we are kind of matching them with respect to just 1 year back, kind of similar cohort who did not see COVID. So the idea is that in case there is, let's say, for whatever reason, we do not know, but let's say for whatever reason, there is a general trend that from April to July, somehow, people listen to phone calls more, for whatever reason. That will be controlled for by the control group. So in order to make sure that those kind of trends do not, create, kind of contaminate our results, so we have a control group. So we are matching the treatment group with respect to control group, and we are seeing how that difference changes, so that the econometric, technique becomes the difference of the difference of these differences, right? So that is how, we can carry out kind of a DID kind of estimate. So the data set I have already, discussed. I'll not get into the details of it. Let me just, quickly tell you about the main results. So one of the questions that we had is the first question, that was the duration of these calls, did it increase during the COVID time? I mean, with respect to the control group, obviously. So everything will be interpreted in a relative sense, but the answer is yes. So women listen to these calls more, because remember that we can actually observe exactly till what second did the women listen to a given call. So we see that, that went up. Then the question is whether any other demographic and pecuniary or even non-pecuniary kind of factors were there affecting, this technology engagement. So there we see that, a couple of interesting things emerge. The first one is that women who were non-owners of mobile phones, their technology engagement increased relatively. So that is very interesting, because this is kind of intuitive. If someone already had the phone, then probably they were already engaging with technology. But if the phone belonged to their husbands, and now with respect to COVID, the husband is also at home, so therefore the phone is available. So therefore the increase in engagement for them is larger. So that is something that we recover from this. The second one is actually slightly more difficult to explain or kind of think about an intuition. The second one is the women who were enrolled through the program and access information by community workers, they increased their engagement more compared to the women who went out on their own in order to get placed. So initially our hypothesis was honestly the other way around, that those who already went out by themselves, they would be more interested or at least more attentive towards information provision. But in our estimates, what we see is that apparently those who were registered by this community workers, so basically for these women, these urban community workers came to the house to enroll them. Somehow they reacted more. So there is one interpretation of that, which is that one possibility. It's almost like how we know that marginal, return of something diminishes as something kind of piles up. So there is a possibility that those who went out on their own in order to get registered, they already acquired a lot of information. So they were already kind of saturated with information. Whereas the ones who were, who were registered by these community workers, they were on the low end of information. So the marginal return of information is very high for them. So therefore they were reacted more. But that is, to be told, it's more like an exposed kind of argument rather than an exact hypothesis was the other way around. The third one is that we do not have a very good, idea about their specific incomes, but we have a ballpark number. So basically the problem is that when they are asked about what is their exact income, what is their income, they are not asked the exact value. So they are given ranges and so on. And sometimes it's not very, clearly categorized. But again, what we see is that poorer women, so this is kind of intuitive, poorer women tend to react more. So which is again consistent with the other ideas. It can be correlated with many other attributes, or directly it can be the case that poorer women have no other sources of information. This is the only thing, so they are holding on to it even more. So roughly these are the observations that we make. So just to kind of summarize and think about what lies ahead, is that one thing that we kind of tried to understand through this paper is that what are the kind of demographic variables which affects technology engagement. So one thing that we really see is that technology engagement depends a lot on time and availability of a technology. And one bunch of analysis that we do, if you remember, I talked about how we can see this green zone, orange zone, and red zone. So this result I did not, account for here in this set of slides. But what we see is that after COVID, the density of women in the red zone does not change. So those who are not listening, they are not listening either way. But what happens is that there is a lot of switch from orange zone to the green zone. So those who are listening to a moderate amount, they switch a lot to green zone. So they are kind of listening to the full message. So the idea is that most of the switch that we see, or most of the major changes that we see, is due to the women who were somewhere in between. Those not in the extreme. Those in the extreme. So let's say the ones in the extreme left, those who are not listening at all. They are not listening at all even after COVID. Those who are extreme right, listening to the full messages, in any case, they're listening to the full messages. So there is no switch. What we see is that those who are on the margin, they switch towards the green zone. I will take, Tarun, can I have 2 more minutes? I know that I have run out of 20 minutes. Okay. So I will just quickly, tell you about one thing. So if you have done Micro 101, then there is one way to think about it, that we have all done this, labor leisure choice kind of a, model, where a worker can choose how much labor to have and how much leisure to have, with the constant that labor and leisure adds up to a finite amount of time. So it can be, one can think of it like, if I have 24 hours, how can I split it into some amount of time that I can work and some amount of time when I just enjoy. The idea is that then there is an opportunity cost of leisure, because if I am consuming, let's say, 1 unit of leisure when I'm not working, even if I'm not paying a direct price, there is an opportunity cost in the sense that I could have worked during that time and earned something. I am missing on that part. So there is an opportunity cost. So by changing wages, one can change the opportunity cost of engagement, and therefore there can be an effect on labor supply for that. One way to kind of think about this whole idea, that everything that I have talked about, would be, instead of leisure, consider technology engagement. So there can be an active trade-off between technology engagement and, let's say, doing work. So most of the things that I have talked about is basically related to time endowment, that if the phone belongs to someone else, then, so suppose a woman's husband goes out, then she has to also go out in order to fetch the phone and talk, etc., etc. There is an opportunity cost involved there. Similarly, even when the woman is engaged in some kind of a job which requires, most of these jobs require constant attention, it's quite likely that even if there is a phone call, she cannot listen to it, because again, there is a trade-off. If she picks up the phone call, then she might lose some customers, or somehow might suffer in terms of her work. So one can think of kind of pitch it with some very basic indifference curve and budget constraint, and show that due to COVID, when the time constant remains identical, everyone still has the same amount of time, but the relative price between technology engagement and work changes, because there was no work during lockdown. So what happens is that the technology constant becomes more binding. So kind of this red line kind of switches, rotates to left, and this becomes like, from B1, it becomes called like B2. So there is an overall shift of the indifference curve, and one can think that how technology engagement can actually increase in those cases. So this is just a releveling of basic labor leisure choice, where I'm just releveling leisure by technology engagement, and the same kind of argument goes through. I'm not saying that there is a very serious microeconomic argument, but there is just a way to think about it. So what are the future works that one can think about? One of the major problems of our study that during all of our presentations we came across is that we do not know whether it leads to good health outcome. So the outcome is seen only in terms of whether the women actually successfully gives birth or not. But the thing is that that technology is so stable that listening to phone calls or not will not have a major impact by changing, let's say, rate of birth or rate of successful deliveries. So for that, probably we need much more fine-grained measure as something like maybe vitamin level or iron level. Okay? So we do not have access to any of those. So the question is, to what extent there was a welfare effect? Honestly, we do not know. The second big question that we again do not know of is that even if there was a shift in this behavior, whether it's persistent or not, and this is something people in this literature, and Tarun is an expert on this, the first thing people would like to know is how persistent it was. So again, from this, we cannot tell much because this was really a short period of time. And then there were other problems that, this particular organization, although we have like a lot of phone call wise, we had almost 2 million data points. The problem is it's geographically very concentrated. It's only within and around Mumbai. So we do not have a lot of urban-rural variation, let's say. So these kind of demographic heterogeneities we do not see. But by and large, what we see is that we contribute to this whole literature on health information dissemination and effects of health shock on technology engagement behavior. We hope that at least it leads to some more conversation around it in the Indian context. And I know that my fellow panelists, they are actually doing a lot of work in terms of thinking about e-intervention in the healthcare context. So I will stop here and looking forward to listen to all of your thoughts. Thank you very much.
Okay, thank you so much, Anindya. I think this is a fascinating summary of a very important intervention that happened during the lockdown. And so I do have a couple of questions. I'll sort of maybe reserve my questions for later. But right now, Hardik, would love to hear your thoughts, both on the research, but also generally about what's happening in the industry and what's new and exciting about in this domain that you'd like to share with us.
Absolutely. Thank you, Dr. Jain. So Anindya, I think this is fantastic research. I had gone through the paper as well, and thanks for the summarization here as well. I think it's what I think the Indian healthcare ecosystem lacks today is research which is localized, which is built upon the Indian context. I think that research is really worth its weight in gold. I think we all need to collectively figure out more and more ways of managing, like the pandemic was a very complex and almost an insurmountable healthcare situation, which all of us were part of. These sort of situations can happen in the future as well. Today, we are all doubly vaccinated. We all have taken booster shots. We all feel much safer now. But 2020 and 21 were really difficult times. I think a lot of us have suffered losses in our friends and family. It was a really difficult scenario for anyone to prepare for. And it showed that the Indian healthcare ecosystem was not ready for a shock like this. Some of the things which are a positive is that through your research as well, it shows that technology engagement has increased, especially in the healthcare scenario, where now people are probably more open to understanding how can I improve my immunity, what can I do better for, and in this particular case, what can I do better for the child that the woman is bearing, right? So I think research with localized research with the Indian context, I think, is absolutely the need of the hour. We absolutely need to have more engagements, discuss more about it, make it a top of the mind topic, engage more with government as well. And I think the momentum is building on those things. I think through the pandemic, the government has also realized and taken excellent steps towards building out public health infrastructure. So the case in points here are that Aarogya Setu has become sort of like a common platform for dissemination of information, or like we saw in the whole vaccination process. It's almost become like a cornerstone of engaging with the public and creating awareness, getting people onto a common platform, getting them vaccinated, spreading the right information, clearing out misinformation, etc. And while Aarogya Setu is one aspect of it, which is much more public facing, I think what the government is doing with the NDHM, or now it's called the ABDM, is setting up protocols to ensure that India takes the right strides in terms of electronic health records, how these records get generated, how they are transferred, how they are made available to the individual themselves, how they can be transferred between institutions, between healthcare professionals, and how overall, whether it's a healthcare professional or let's say a hospital or an institution, how they can take much more informed decisions using digital versions of your healthcare information, right? So I think now is the right time to actually conduct research like the one you've done and take it forward, take it to the next step, and really make it about outcomes. As you rightly pointed out, Professor, ultimately it has to be about outcomes. How are we affecting healthcare outcomes? Technology has a role to play, but it cannot play the entire role. I think technology can do the role of providing accessibility, providing right information at the right time to the right person through the right interface. But I think ultimately it is how we are connecting the stakeholders of the ecosystem through technology and how we can use that to create the right outcomes. I think that has to be absolutely the end goal for it. So I really loved reading about the paper in terms of how you've categorized income, ownership, and the channel through which the women are enrolled. I think these are three quite important aspects in terms of how do we measure engagement or the improvement in engagement. I think it was really interesting to go through that and understand it. Overall, maybe from a, if I just rewind the clock a couple of years, at the beginning of the first wave, we did a couple of things which were in the similar domain in terms of what the NGO is also doing. And so we basically helped out the BMC, which is the Mumbai Municipal Corporation. During the first wave, the first lockdown, we worked on building a chatbot plus a helpline. Because this was, if I correctly remember, this was like third week or fourth week of May. And there was a lot of misinformation. There were a lot of people calling BMC. There were a lot of people putting up Twitter posts on the BMC handle. And the BMC was getting inundated with requests in terms of what to do, what's going to happen. People with some symptoms, people with some relatives who had symptoms, people with people in the same building who knew someone had a symptom living above them or below them. So we started getting a lot of these requests and channelizing these requests and creating a sort of a, how do people engage at scale with a public health interface, right? So I think there we worked quickly with the BMC, set up a knowledge base, and built a chatbot on top of the knowledge base and a helpline, so that we could channelize all of these requests and convey to the people that the BMC is working on it. In terms of certain symptoms, we built a symptom tracker and a screening monitor so that we could funnel the people with the most severe symptoms to a healthcare facility near them, or arrange for a ambulance pickup, or get them quarantined, or get them assistance through a doctor. So I think these were things which we did early in the first wave. But even these sort of things, as we got into the second wave, these didn't scale, because you had such a spike, you had such a fast outbreak in multiple areas. The only way you could have stopped the second wave was to probably have very, very robust early indicators set up. And these are some things which we did work with couple of government institutions, but it never saw the light of day. This is something which I would really probably implore more and more research to be done upon, because such outbreaks would keep happening. Even today with TB, outbreaks do keep happening, but they sort of go under the radar. But in terms of how do we understand what are the early indicators, we already have a lot of digital infrastructure set up. We get orders for medicines, we get orders for diagnostic tests. Any spikes, any differences in terms of the usual amount of orders that come from a particular area versus the new normal, I think could be great early indicators. But yes, a lot of research needs to be done on that. I think these would help in probably understanding where an outbreak could happen, with what probability, And if it does happen, what should be the ideal containment zone? How would you react to it as a municipality? How would you provide resources to that particular zone, and how would you try and contain it? So I think a lot of these things need a lot of research. They are very raw in terms of ideas that we have as industry, or certain implementations which the government would have also done, but they're still very raw, and we are not in a position to handle such scenarios in the future. We need a lot of research to be done, and that research cannot be just, in terms of aping the West, right? We have to do research which is much more localized with the Indian context, because we have to serve a nation of 1.4 billion people, and that to a nation which is still a lot more rural than urban. So I think our solutions cannot be the same as what works in a much more developed country, or in a much more urbanized country, right? So I think these are sort of the thoughts I had. But yeah, I really appreciate the effort that Professor has put in and has done research on mHealth, and I really hope that they continue to do the same. And wherever we have some intersection, we would be happy to help out as well, and would love to contribute as well.
Okay, great. Hardik, it's very interesting and very sort of heartening also to hear about your interventions and efforts during the COVID era. In some ways, getting for India to get over the COVID's hump would have been almost impossible if it wasn't for many companies almost putting in heroic efforts, right? We talk about how much the public health system had to learn, but the private health system also had to learn a lot, because this was unprecedented for everyone involved. And I think if it hadn't been for many companies in the diagnostic space, in the sort of drug supply space, and of course we all know about the vaccine manufacturers and delivery space.
Yeah.
Almost for India to escape, given the kind of size we have, would have been almost impossible. I mean, we didn't do a very good job in escaping. I mean, there is a lot of misery that still happened, but I think we think in terms of counterfactuals, and sort of thankful for all the people who did do the work.
Exactly, and just a moment on that, Professor. So essentially, when the first lockdown was announced, we were not sure like how many people would turn up to work the next day. We were part of the essential services, so we were allowed to work.
Yeah.
But we were not sure how many people would really turn up to work, right? I mean, it was still, for them, it was getting out. It was the unknown. You wouldn't know kahan spread ho raha hai, kya ho raha hai. But we had like the highest attendance levels across our facilities during the first 3 months. Even in the second wave, when we had at any point of time during the second wave, we had at least 100 people in our workforce who were COVID positive. And we sort of like had a crack team internally to look at their situation, provide them nursing support, provide them medications. But still, even in such dire situations, and obviously we all know the situations in the major cities like Delhi, right? These were very dire situations, and still people were turning up to work, working in our facilities, delivering medicines, delivering diagnostics. And the same is true for all other folks, whether it was on the private side or on the public side.
Yeah.
Unfortunately, we lost 4 employees as well. So it's quite heroic what people have done. They've showed amazing courage. But yeah, I think what's great is that when you're in the healthcare sector, I think there is a natural calling in terms of the outcome, right? If you really work well, I think there can be really fantastic outcomes. And I think that's what really gels everyone together. Like there's a lot of people in the company with diverse backgrounds, but what everyone really comes here for is not to build technology that they can do in many other companies.
Many places, yeah.
But really the impact that you get by building the right technology for India, for the Indian healthcare ecosystem, I think that really resounds a lot or resonates a lot with all of us.
So let me just turn to many of your attendees. So I see Dr. Saab Gaurav Patil. He has his hand up for a while. So Dr. Saab, can you unmute yourself, please, and ask your question? No. Anyone else wants to ask a question? There are no other questions?
So if there is no one else, then maybe I can ask a
Yeah,
question
sure.
to Mr. Dedhia. So I think I was just wondering that given this, kind of multifaceted operations that you, let's say, in terms of pharmacy, which dimension of these, of these operations do you see most susceptible to, technological disruption? So one thing is that, I mean, this is from an outsider's perspective, I suppose, that idea about a robust supply chain kind of became much more prominent post-COVID, due to various reasons. And that was clearly, due to a lot of changes in infrastructure and so on. So not the medicine component of it, but there is also an additional development which makes this possible. So let's say in the context of pharmacy, what specific dimensions that you see which is mostly getting disrupted or changing on a kind of rapid basis?
So we've sort of now been at it for almost 10 years. So we've seen quite a bit of change in the industry in this 10 years itself, right? Like from a 2014 to 2018 sort of a period, we saw massive disruption in terms of how people thought of ordering medicines. Like online pharmacy as a concept really developed in that period. And you could see that in 2014-15, people started ordering food online, and like sort of the Swiggies and the Zomatos, and there were a lot more players at that point of time who really came up in that period. And we sort of took it from there, that if you can order food, why can't you order medicines? But when we sort of got into it, we realized that unfortunately the awareness is so low that people don't know what a prescription is. And we obviously needed that to service the medicine. So sometimes disruption can happen because of some things happening in adjacent industries. But then to bring it into healthcare and to completely contextualize it is a very, very difficult thing, right? Currently, what we are seeing over the last 2 to 3 years is that now people are very comfortable to get diagnostics done at home, especially after COVID. They are used to getting COVID tests done at home or any other things as well getting done at home. But the thing is that when you go to a particular lab, you have the phlebotomist who's present at the lab. Now here the phlebotomist has to really, like, the inventory is the phlebotomist in a way, right? So technology can play a role in terms of improving accessibility, but sometimes it's the other way around. Convenience and accessibility are sort of canceling out each other. You want convenience, so you want the phlebotomist to be at home, but then how do you share the phlebotomist across so many other people, right? Because now the phlebotomist has to travel from one point to the other. So there are a lot of these disruptions which are sort of in a way canceling out each other because healthcare is so much more contextual. But yes, we've absolutely seen that two major disruptions is that how do people look at accessing medication and accessing diagnostics from home. What I think the next would be, or what we are also working on, is how do you build a much more omni-channel experience, that ultimately I want to get a test done. It's up to me what's the urgency, what's the immediacy, what's my cost, what's the cost that I'm willing to bear, what sort of convenience do I want, and can we really connect more or grow the network in a way where today I either have to choose, is it online versus offline, but can I just make it a lot more omni-channel in nature? Can I make it a lot more convenient in terms of choice itself, right? So you could order online but pick it up from somewhere, or you could place an order somewhere and just get it delivered at your office. So this is where we see, at least in the urban side of things, this is where the trend we see it is getting into. But yes, from more of a health perspective, like our view is that the last 8 to 10 years we spent so much time on the supply chain side of pharma. We are actually not a healthcare company yet. We have to still look at healthcare outcomes. The major metrics that we follow, the major KPIs that we follow are actually supply chain metrics, right? In terms of fill rates, in terms of turnaround time, in terms of end-to-end delivery time, in terms of mistakes done per 1,000 deliveries. A lot of these metrics, and even on the diagnostic side, right? The turnaround time or adherence to the slot that we give you, these are largely supply chain metrics that we follow. Have we really implemented technology which is bringing us amazing healthcare outcomes? Not yet. We are still in that journey. There is a sort of a new initiative which is going on in the company in terms of how do we make access to surgeries, elective surgeries, easier, in terms of the entire process of, hey, I need to get a knee replacement done, but what is the most cost-effective way to do it? What is the way in which I will have the least rehabilitation issues? I'll need to take the least amount of leaves from my company, or my post-rehabilitation will be taken care of. My insurance will also be done in a cashless. I mean, my payments will be done in a cashless manner through the insurance that I have. So I think these are questions which people have, which are not really the health question itself, but in and around it, how it's going to affect my life as I enter into a surgery. So I think there also there is a lot of disruption possible through technology, and bringing all these stakeholders together: the hospital, the surgeon, the patient, the family member, the insurance company, or the agent. I think bringing them all together on a platform is challenging, and I think that could be the next big thing as well.
There's a Dr. Shalini Agarwal. Can you ask a question? I think you have a question about like what's happening in government hospitals. But let me ask you to articulate your question directly instead of me summarizing it for you.
I'm really sorry. I missed the initial part of the presentation, but I'm keen on knowing. I would very much like technology to be incorporated in our government colleges, and I just don't see a change post COVID, meaning I don't even see anything in the pipeline. So can somebody enlighten me as to, I mean, after COVID, we should have, we should understand the importance of technology and diagnosis, and if we haven't understood it till now, then
sure. So let me, I think the contrast between what's happening on in both private sector versus public sector is stark, in the sense that you see a lot of innovation rapidly permeating the private sector, but not so much in the public sector. The second, I think there's Dr. Sahab Patil, who also had a point to make in the Q&A about rural areas versus urban areas. And I think you see much more rapid technological dissemination and diffusion in urban areas and not so much in the rural areas, right? So, and I think this is the point that both of our questioners are bringing out. So we have 5 minutes left for this. So let me ask both my panelists to sort of collectively address this point. That, I always worry about, the haves and the have-nots, right, in some ways, as well as fast-moving sectors versus not so fast-moving sectors. And so what does it take? I think Hardik made this very important point that we should be doing research for India, and we should be doing innovation and technological dissemination in India. But India itself consists of many different parts, right? That you have the haves and have-nots within India as well. So how do we motivate more technological diffusion, and particularly so that we help those people perhaps who are most in need?
So, Tarun, can I go ahead?
Yeah.
Or maybe, yeah, please.
No, please go ahead. Please.
So let me just propose one side of the spectrum. I think there are two ways to look at it. That one thing, when we started thinking about these kind of problems, we started thinking of them in terms of, in basic economics, the way we think of demand and supply, which eventually leads to some kind of equilibrium in terms of, let's say, quantity and price for any markets. We can think of it exactly in the same way, that there can be a supply of technology and there has to be a demand of technology. Now, the supply side, Hardik is something, working on that, and there are many other companies which are precisely working on that. So many of these questions from Dr. Shalini Agarwal and Dr. Patil, these are basically about the, question is much more about the supply side, that what is the response of the supply side. I would like to kind of shed some light on the demand side as well, because this is something, this is where I think economists have made kind of very important contributions, noting that people's behavior can be very sticky. So often what happens is that the supply side solutions are there, but due to various reasons and frictions and stigma and whatnot, people simply do not, there is no uptake of it. People simply do not, go by it. So one of the, one very easy example of this is something that is very common in, commonly discussed in development economics, that we know that, mosquito nets reduce malaria. So it's a preventive kind of thing. It's not a medicine per se, but it's a preventive measure. But people simply would not, a lot of people simply would not utilize a mosquito net, even if they know that there is a problem that is waiting for them going forward. So in our context, in the context of the paper that we described, I think one of the good things that has happened is that people are now much more aware of very small changes in their behavior, which can lead to very big changes in the outcome. And both in a cumulative sense as well as on a marginal sense, in the sense that, so just maintaining social distance, does it reduce a lot of other kind of diseases which correlate with something like a flu or not. So general hygiene, etc., etc. So I think people are much more kind of, people take cognizance of that due to a lot of these things. So what is also happening is that there is a behavior shift and much more appreciation towards understanding the utility of some very basic prevention mechanisms in order to stave off much bigger loss in terms of healthcare that might actually appear. Given that that is happening, at least at the policy level, so there was I think Dr. Agarwal was talking about the government medical colleges and so on, but at least at a policy level, what we can now see is that the policymakers are now really thinking, even in the context of India, where, as Tarun pointed out, there are literally most of the people are have-nots rather than have. So thinking about a kind of universal insurance scheme, where this was kind of unheard of or unthought of earlier, even let's say 20 years back, or maybe even 10 years back. But now the policymakers are thinking about these things, that there can be kind of a much more complex scenario where one does not simply go out to purchase medicines when and where that they have already contracted the disease. So where the cost is already much larger, and it requires much more serious attention. So the prevention component, the support coming from the policymakers, etc. These things are now much more prominent. They are not only part of it's not a theoretical discussion anymore. It's very much in practice today as of now. Does it mean that no?
Can I interrupt?
Yeah, sorry, please go ahead. And then
actually, I feel that there is a lot of discussion on this topic. I have a lot of ideas, I wish I had the means to implement them, because, we keep saying that there is no demand, but, you can create demand by simple things. In olden days, we had this bioscope, so you can make the have-nots aware by simple things like a bioscope. You can show movies, because movies are generally not there in the villages. So, you can make those movies small, like you can have Saturday night movies based on some, like Akshay Kumar's, Swachh Bharat, have a toilet kind of a thing. I'm sure they will make a lot of impact. Then something on vaccination, and as I'm saying, I have a lot of ideas. It's so easy to talk about policies and, things not reaching the ground level. But I hope somebody's thinking about these simple little things that can create awareness in terms of what the have-nots are used to. So I'm sorry, that's all I want to say.
Dr. Agarwal, just a quick
so
point.
It's past 5 o'clock. So let me just sort of, interrupt at the moment. So I think, Dr. Agarwal, we're very happy to hear some of your ideas. Maybe Maya can just type in an email address for CMHS in the chat box, so that there's a way for everyone to get in touch with us. But at the moment, and Dr. Agarwal, right, so that Dr. Agarwal, we can engage with you more constructively It's sort of because, it's not unlikely that over the next 5 or 10 minutes we'll be able to do much, but we are an action-oriented research center. So in that sense, we are very keen to hear from you and your ideas and, perhaps take the conversation forward. For my fellow attendees, thank you so much for attending the talk. But I'd also like to thank both my panelists, Dr. Anindya Chakrabarti, as well as Mr. Hardik Dedhia, for a very stimulating discussion. I think so what I take away from this is that the scope for the kind of work that they're doing is very large. And we've just sort of managed to scratch the surface in the kinds of populations that are being reached, as well as the scope of the work in terms of the number of functions that can be transformed using technology. So I look forward, of course, to both your research as well as your firms implementing much more, because it's exciting days for India, because we're certainly on the growth path, right? I mean, this is very early days in all your work. So thank you so much. And of course, I really appreciate the efforts of Harshad Zala and Maya Swaminathan from the Center of Management of Health Services, who did all the hard work for putting together today's webinar. Thank you very much. And good day to all of you. And I look forward to your attendance in more CMHS seminars. Thank you so much.